welcome you to the first PSG Health Insight podcast. We are excited to embrace this technology because of the convenience and reach it enables. In these podcasts, we will address the draft demarcation regulations and the potential impact of these regulations on the future of health insurance products such as gap cover. We also focus on national health insurance, where we interview the 3 largest open medical schemes to elicit their views on the possible impact NHI could have on the private healthcare industry as a whole. In addition, our Head of Healthcare, Cranke, will provide an industry update with specific reference to the annual report recently released by the Council for Medical Schemes. As leading advisors in the areas of healthcare consulting and employee benefits, we strive to empower our clients to make informed decisions. Our healthcare client base comprises of almost 140,000 medical scheme and health insurance contracts, representing approximately 400,000 individuals. We believe that our independence, Level 1 BEE status, unique business model, scale and skill set enable us at PSG Konsult Corporate to continuously meet the requirements of our clients through best advice and service excellence. We trust that you will find the podcast information insightful and relevant in equipping you to make sound healthcare decisions during the year-end renewal process. Lastly, I would like to thank all of our clients for your valued and continuous support. And should you have any questions or feedback, please do not hesitate to contact me personally or your dedicated healthcare advisor. Thank you very much.
Making decisions about the healthcare provisions of your employees can be daunting at the best of times, and doing so in an ever-changing legislative environment can seem impossible. As part of our mandate to assist and guide you in the decision-making process, we've gathered leading experts in the healthcare industry to discuss key issues facing decision-makers in the workplace. We trust that these podcasts will provide insights and clarity, enabling you to make a more informed decision. Leading the discussion is Anton Le Roux, Head of New Business Development at PSG Consult Corporate, and he'll be talking to Tiago de Carvalho, the Managing Director of Ambledown Risk and Underwriting Managers, specializing in the area of health insurance underwriting. Tiago served on the South African Insurance Association Demarcation Work Group and was pivotal in consulting to various interest groups on their submission to the Department of Treasury in respect of the draft demarcation regulations. And John Cranke, the Head of Healthcare at PSG Consult Corporate. John has more than 28 years of experience in the employee benefits industry, with the last 10 years being in the medical scheme industry. He was also responsible for drafting PSG Consult Corporate's response to the draft demarcation regulations.
Tiago, John, welcome to PSG Health Insights, and thank you for your time this morning. The publication of the short-term and long-term demarcation regulations by the Treasury, National Treasury, in March this year caused quite a bit of a stir in the industry, particularly with regards to gap insurance products. Could you perhaps just, Tiago, explain perhaps the practical ramifications of that on members?
Well, the peculiar drafting of the draft demarcation regulations proposed to introduce 7 new categories of health insurance in health and accident policies, namely lump sum or income replacement policies with benefits payable on a health event, motor or property third-party liabilities, benefits for AIDS, HIV, domestic and international travel insurance, and emergency evacuation and transportation. The effect of the regulations is that any product that falls outside the scope of the regulations, such as gap cover, will be outlawed in the future.
I understand, but I also know that these are only draft regulations at this stage.
That's correct. The proposed draft regulations were introduced on the 2nd of March 2012, and the public was given the opportunity to comment until the 23rd of April. There was overwhelming response from both public and the various stakeholders, and National Treasury are busy going through all the submissions and they will provide a response.
This is not, as I understand it, the first attempt by regulators to abolish these type of products. There was also an attempt by Council of Medical Schemes in 2007-2008 to abolish health insurance products.
Yes, the guard risk versus the Registrar of Medical Schemes, another case. In 2006, the Registrar of Medical Schemes, together with the Council for Medical Schemes, issued an interdict against guard risk, prohibiting guard risk from marketing their gap cover policies. Guard risk contested the interdict. The entire argument was surrounded on the legal interpretation of the definition of a health and accident policy in both the short-term and the long-term insurance acts. After 2 years of a legal battle, the Supreme Court of Appeals found that the guard risk gap cover products or their policies were both lawful and in line with both definitions. I'd like to quote the ruling by the Supreme Court of Appeals, and they basically said that conceivably to make provision for obtaining of any health service could mean an undertaking to the service provider to make payment for all or part before the health service is undertaken, and that is the business of a medical scheme, which is quite different to actually assisting and defraying expenditure incurred in connection with the rendering of a health service. They also, I think it's important to add that the Supreme Court of Appeals added to the ruling a statement on gap cover, stating that practical reality shows that there is a need for this type of insurance and there seems no reason not to make it permissible.
Am I correct in assuming that this time they are attempting to change the definition of a medical scheme, and so what will be the impact of that?
That's correct. They proposed a change to the definition of a medical scheme in the Financial Laws General Amendment Bill, which is open for comment to the public.
And not long after the publications of these draft regulations, there was also a media release by the Minister of Finance, Pravin Gordhan, and I want to quote a bit of this, that stated basically that the regulation seeks to address risk and possible harm caused by health insurance products, drawing younger and healthier members away from medical schemes onto the health insurance platforms. Do you believe indeed that these products do that? Do they draw members away from, the healthy members away from medical schemes onto health insurance products?
I don't, Anton, not at all. Gap cover augments medical scheme benefits, and it's always a condition of a gap cover policy that the member is a member of a registered South African
and
medical
that is a condition
schemes.
right through the industry. So in other words, all gap products.
I believe so, yes. Other products that exist, such as hospital cash or personal accident policies that do defray medical expenses in terms of personal accident policies, are available to those who cannot afford the most basic of medical scheme benefit options. One must consider that only 15% of South Africans are privileged enough to afford medical scheme membership. The remainder, which is the vast majority of all South Africans, seek other products to provide the most basic level of care.
And Anton, I think, sorry, just to interrupt, I think that's quite an important point, is that we mustn't blur the lines between health insurance products and gap products themselves, because the gap products rely on the policyholder firstly having a medical scheme cover and cannot have that gap cover product as a standalone product with the absence of a medical scheme, which is the case on some of the other health insurance products out there. So it's a very, very important point as far as the gap cover scenario is concerned.
How would you respond to the claim that the draft regulations serve to strengthen and to preserve the social solidarity principle which underpins medical schemes?
Well, gap products are not priced on traditional insurance means. Pools are created by various insurers, which creates a form of cross-subsidy. So I don't believe that's the case at all.
Do you not believe that once members opt for gap products, that there's the real risk then of these members, particularly the sicker members, buying down from more comprehensive options onto more affordable options? Is that not the real risk? And is that not a challenge for medical schemes?
Anton, I think I respond by trying to separate the two main instances where members make selections. And the first one is when they join the medical scheme. And in our experience, very few medical scheme members at the outset actually select the option that they join based purely on need. Very often it's driven by the affordability. To give you a sense, we've actually adjusted our medical needs analysis form to accommodate that question about what is the budget available to the person that our consultant is dealing with at the time, in order to drive that option selection ultimately, rightly or wrongly. But the affordability is a major factor. In addition, there's the reality that there are very few options on very few schemes where you could say hand on heart that scheme or option could guarantee that the member and his or her beneficiaries would have absolutely no chance of having some sort of shortfall were they to be hospitalized. And the second instance is the annual opportunity that members have to change their options either by upgrading or downgrading on the scheme that they're on. And I think it makes more sense from our point of view that the downgrades are driven to a larger degree by the fact that the medical schemes are passing on higher than inflationary increases and have historically done so. Now that opens up a whole separate debate, but the fact of the matter is that if you're an employee and your salary is keeping pace with inflation and the medical scheme increases are exceeding the pace of inflation, something's got to give. And I guess the best example I could make is by looking at pensioner members where due to buyouts and whatever, there's an increasing amount of pensioners who no longer have subsidies post retirement, and where they have other factors impacting on their pocket as well, like the increases to the fuel prices, which we know very well, electricity tariff hikes. They're often facing a scenario where if the medical scheme is also increasing at higher than inflation, and they are on a static pension, ultimately they're painted into a corner and simply have to downgrade.
Do you have statistics to support your argument?
Anton, when we prepared our submission on the draft demarcation regulations, we actually conducted a review of 11 medical schemes that represent in excess of 90% of the open medical scheme market in terms of membership numbers. And it was very interesting for us to see that only 36% of the options in those 11 schemes made available the opportunity for a member to insure themselves at anything higher than the base medical scheme reimbursement rate. In addition to that, we saw that 4 medical schemes simply didn't have an option on the scheme that offered anything higher than the base medical reimbursement rate.
I understand. So in other words, these members actually cannot buy up to a more comprehensive option.
That's entirely correct. For those 4 schemes, if anybody in that family that is covered is hospitalized for any hospital procedure whatsoever, in the absence of any tariff agreements with service providers, they would almost certainly have a shortfall, and that could amount to several thousands of rands. But it actually goes beyond that, because even on the schemes where they do have higher reimbursement rates, often members find those unaffordable to them in any event. So they are, one way or another, going back to the affordability issue on an option where they simply are going to be faced with a shortfall if they're hospitalized.
If I understand it correctly, neither of you actually believe that these regulations, or these products in fact, negatively impact on medical schemes. Are there any evidence that support or refute this?
No. There's never been analysis done on the impact gap cover has on medical schemes, either quantitatively or qualitatively. I think it will be very difficult to quantify the impact, but a qualitative study on the impact of gap cover on medical schemes would be welcomed by the industry.
And from an intermediary perspective, John, would you support an investigation or a study of that nature?
Without a doubt. I think for us, adding to the confusion is the fact that medical schemes themselves have taken up opposing positions. We've seen some schemes that are opposed to them, and they've been given some airtime in the media, and other schemes who in fact endorse the gap products and in fact even have their own arrangements that are tailor-made to fit their options. So without a doubt, we would support that kind of research, yes.
Yeah, that's quite positive. Tiago, how many members do you think these regulations would impact? What's your guesstimate?
Well, as John has alluded, there's no real central repository of health insurance products. But we estimate that there's roughly 300,000 families covered by gap cover policies.
In my guesstimate, that's about 3% of the medical scheme market, if I look at my figures here.
Yeah.
That's correct.
Is the state of private healthcare cover so fragile that this could truly have a significant impact on the industry?
Well, Anton, I don't think anybody can contend with the fact that medical schemes are in a particularly turbulent time. Probably the biggest challenge they're faced with is the increasing healthcare costs. But they're working with a stagnant membership pool as well. Added to that, the fact that the High Court ruling earlier this year made it obligatory for them to reimburse in respect of the prescribed minimum benefits at cost in full. These are all things that are placing additional pressures on them. We feel that especially where there's no tariff agreement, there's no ways that the finger pointing can hand on heart be done to the fact that it's the health insurance products that are undermining the medical schemes. There are a whole variety of factors at play.
I know that healthcare members have many options these days. There's lots of choice in the market, and I'm just wondering, and it might be a difficult question, Tiago, but I'm going to pose it anyway. Do you envisage that these regulations could potentially infringe on the Constitution and the constitutional rights of people?
I personally believe so. Section 33 of the Constitution gives us, society, the right to just administrative action. It allows us to challenge administrative action, and in so doing it compels us as a society to ensure that government is democratic, accountable, open and transparent. Regulation is subordinate legislation and is considered by the Constitution to be administrative action. The Constitution requires that no administrative decision may adversely affect anyone's rights, and adversely means a decision taken which cannot impose a burden or have a negative impact on anyone, and that includes unjustly requiring someone to do something, tolerate something, or not to do something, to limit or remove anyone's rights, and decide someone does not have the right to something. This is called adverse determination of a person's rights. Unjustly denying the policyholder of a gap cover policy the individual's right to choice is unconstitutional. This is so as no evidence exists or was provided by the regulator showing that gap cover policies compromise the key principles of social welfare, solidarity and cross-subsidisation found in medical aid schemes. In this instance, administrative decisions adversely affects the rights of South Africans by denying consumers their democratic right to provide for an unforeseen event which could have had or lead to financial difficulty to the individual.
So there's potentially a case to be made.
Yes, there is.
Can I just find out where exactly do we now stand with the draft regulations?
Well, as I said earlier, we're waiting for response from the National Treasury. As it stands now, gap cover products are legal, and we wait for a second round of draft demarcation regulations, which we'll understand will be submitted by National Treasury before the end of the year.
John, to me it sounds like a regulatory minefield at the moment.
Yep.
And I suppose from an advisory capacity, what do you tell clients that are currently on gap products? Must they sit it out? Must they?
Well, Anton, we certainly have empathy for our employer groups. It's as I said earlier, it's a turbulent time in the healthcare industry overall. But our recommendation to our clients is that they should sit tight. I think Tiago made the point quite correctly that although there's this whole discussion going around the draft demarcation regulations, the fact of the matter is they have legal standing as it stands right now. So we would say sit tight. We believe the products have a place. We've got an example where recently one of our extra care members received a reimbursement to the tune of 69,000 Rand for an in-hospital procedure. Now, that is something that could potentially bankrupt someone. So, particularly in the current environment where we don't have any kind of determination regarding tariff negotiations between providers and the medical schemes themselves, we feel that these gap products are probably more relevant than ever. I think just to not beat about the bush, we feel that if you're on gap cover, stay there. It still has legal standing, and it's relevant.
Thanks, John. And Tiago, in summary, do you concur with that?
Absolutely. We also remain positive that after considering all these submissions, National Treasury will make a U-turn. It's important to note that these gap cover policies will remain legal until the end of December 2012. And if there's a second draft of regulations that come, we'll adjust our policies to meet the requirements of the individual consumers.
Thank you, Tiago. And then just in conclusion, it's evident to me that members who currently are on these products find themselves legally on these products. It's still legal. It's a necessity in our industry. If I look at the shortfall, the medical scheme shortfalls, particularly in terms of in-hospital expenses. So the advice would be for members to, John, as you said, sit tight and remain on these products. In the interim, we will await further regulation. And obviously, from a PSG Konsult corporate perspective, we will endeavour to continue to keep our clients informed on developments.
Absolutely.
Thank you very much.
Even though there are no definite answers on the outcome of the demarcation debate as yet, it seems as if the consensus is that you should not be looking to change anything until there is a definitive outcome. And PSG Konsult Corporate will make sure that you have the information at hand to do so.